But it's great to see some familiar names and faces. We've got a lot of information we're going to try and cover in the next 90 minutes. So let's jump right in. As I said, I've got a few introductory slides we'll do, and then I'm going to turn the floor over to Dr. Ignacio so he can share some additional knowledge. So good afternoon or good morning to all of you, wherever this broadcast finds you. This is our Essential Substance Abuse Skills webinar, an ongoing series. We have this first Wednesday of every month, as some of you may know. And today's topic is going to center around HIV, STIs, and substance use disorders. So I want to welcome you again. Hopefully this broadcast finds you well. So I'm going to go over a few introductory slides, and then I'm going to turn the floor over to Dr. Ignacio. As most of you also may know, this event is brought to you by the National American Indian Alaska Native Addiction Technology Transfer Center. We are located at the University of Iowa, and we are part of a national ATTC network made up of 10 regional centers, a national Hispanic and Latino center, as well as a national coordinating office located at the University of Missouri. Again, this project is supported and funded by SAMHSA. The content is developed by the presenter, and the opinions expressed today do not necessarily reflect the views or policies of SAMHSA, HHS, or the American Indian Alaska Native ATTC. Just a couple orders of business before we get started. We will be providing links and slides to this presentation. I'll talk with Dr. Ignacio about sharing these in PDF format. We just remind everyone that if you are going to, let's see, Matt, I want to get that recording started again too.
I got it. I started it.
You got it. Wonderful. Thank you. Just want to remind everybody, if we do share slides with you, that you use them in a good way and give credit where credit is due. So we are going to offer 1.5 NADAC approved CEUs for this broadcast. So we'll reach out to you following today's event and give you an opportunity to request those CEUs. And lastly, I'll place a link in the chat box today. It's a link to a short survey that we ask folks to consider filling out. It is not mandatory. If you're not able to fill it out today, it's okay. We'll include a link to this short confidential survey in our follow-up email to you after today's event. But the survey itself is very brief. We do have a couple of short answer questions so we can hear from you and get feedback from you in your own words. But this survey cannot be linked to you in any way personally. But your feedback is really important to us, and it also lets our funders know that we are doing what we say we're doing. So I will try and keep an eye on the chat box as well as we're going through today's presentation. You're currently muted, but we really encourage folks to unmute if Dr. Ignacio can take some questions at the end, or if something really moves you while we're discussing today's webinar. Feel free to raise the hand raise feature or place something in the chat or unmute and make a comment, and we'll try and pause and address that. But hopefully we'll have a little time, Matt, at the end to take some Q&A, see how we do. Before we get started and I turn the floor over to Dr. Ignacio, I just want to take a few moments. I know we are gathered here virtually today, but we do want to take the time to pay respect to the land and the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 former members of our team from the Meskwaki and Winnebago nations, respectfully. Thank you. Well, without further ado, I want to introduce my colleague and friend, Dr. Matt Ignacio, and I'll let him talk a little bit about his background. We are really thrilled to have him back presenting today. So, um, Dr. Ignacio, I'm going to turn the floor over to you, and I'm going to pull these slides down so that you can transition and get your slide deck up. So let me stop sharing, and I'm going to mute myself and turn the floor over to Dr. Ignacio. So thank you, everybody, for being here.
Thank you, and good day to you all. Skuk dash skuk siadam, wherever it's good morning. So skuk siadam. It is 10 a.m. in Tucson, Arizona. Currently 91 degrees, so it's pretty nice and cool for July out here in the Sonoran Desert, out on the O'odham land, the O'odham Druid. I'm very fortunate to be a tribal member of the Tana O'odham Nation, and also living and working on the land which my ancestors are buried underneath. Let me pull up my slides before I start on this big long. Let's see. Okay, there we go. I'm really excited to be here with each of you today. If you have a chance, put a little shout out of where you're located, just so I can see like later on after the fact where everyone's coming from. I saw someone's from Tucson, so shout out to that individual, as well as Brooklyn. Where Brooklyn at? So great to be with you today. My name is Matt Ignacio. I have over 24 years of experience talking about specifically HIV in and among Indigenous communities, whether that be American Indian, Alaskan Native, or Native Hawaiian. For the first 15 years of my grown-up life, right before I graduated with my undergrad degree, I started working at a small urban Indian clinic in Santa Barbara called American Indian Health and Services. And my first job right out the gate, had no experience, but my first job was to help implement this HIV program in Santa Barbara. And 24 years later, the conversations that I'm going to, or the topics that we're going to talk about today, are the same ones I've been talking about for so long. And I don't mean to say that as a burden. I mean to say that as like, these messages are tried and true, and they have worked in the past. And I want to share this with you all and put this on your radar again, this intersection between HIV risk and sexually transmitted infections, and the fact that people use drugs and alcohol. Taken together, there are inherent risks. And when you contextualize that in and among Native people, where alcohol use rates are above average, where drug and other drug use is above average in some communities, historically, we have had not great access to treatment or even recovery services. But we're in a new era. It certainly is a new era for me. But I hope this information is a reminder and hopefully reignites and restarts the passion to keep this on our radars around sexual health. Because as we'll see in a moment, things are still unclear, and for Native people are not with respect to HIV. I was looking at some data. So let's get started on this. Enough about me. Back to me. All right, so some quick goals and objectives. I want to explain the basics of HIV prevention. Again, I hope this is reminding, or like a good reminder, but if not, then we're going to just cover some basics. Describe some common STIs, otherwise known as sexually transmitted infections. I want to explain some core components of disease prevention. Let's talk about factors that are impacting risk or increasing risk for these things, as well as 2 strategies that providers can use to prevent in their prevention work. I'm not going to get into the core competencies, but this is for you to reflect on. And you will have a PDF of these slides, so you can feel free to look at that later. All right, so let's turn our attention specifically to HIV/AIDS. This is as of 2021. This is off the CDC's website as of this year, this month. What the data shows is that HIV diagnoses in the US and dependent areas, including Puerto Rico and Guam, over time. And so we can see that between 2020 and 2021, looks like there was a sharp increase of 18%. And what that is, it's interesting to note that it might, could be just a basic factor of the fact, as they say, maybe due to the fact that no one was getting tested in 2020 because everything was closed down. And so when folks started going back into care, maybe got an HIV test at that time, and that could explain the increase. But it's something just to be aware of, right? We want to, that's concerning. With respect to differences in new HIV diagnosis by age, people aged 13 to 34 years of age accounted for more than half of the new HIV diagnosis in 2021. So between the ages of 13 and 24 is 19%, and between the ages of 25 to 34 is 37%. That is also the fact that more than half of the new diagnoses are occurring among folks 34 and younger is pretty, that's also something to be aware of as a prevention worker. And now let's take a look at differences in new HIV diagnosis by race, ethnicity. So racial and ethnic differences in HIV diagnosis persist. They have since HIV was first detected and monitored. Racism, HIV stigma, discrimination, certainly homophobia, I'd say transphobia, biphobia, poverty, and other structural barriers, such as lack of access to information, continues to drive these health disparities. And so notably, you'll see that among Black African-American individuals, they account for the majority of new HIV diagnoses, followed by Hispanic and Latino, white, multiracial. American Indian, Alaska Native are at 1%. That, is pretty consistent over time. And then factor in, when I look at this, okay, great, I can see all the different categories, but now it's good to know this. It's good to put this under my radar. I always have questions about how people's race and ethnicity are collected, but that's another day, another training. All right, and now specifically for American Indian Alaska Natives, gotta move things on my way here. The overall numbers are small, as I say, 1%, but again, that's been pretty consistent. And given the fact that our communities are small to begin with, any infection in small communities is a threat, regardless of your race and ethnicity. But in this particular case, the overall numbers appear to be small. In 2018, the rate of HIV diagnosis in the United States among adult and adolescent American Indian Alaska Native males was greater than the rate for white males. So we're talking about a difference of 16.2 versus 9.6. And then when we're talking about American Indian Alaska Native females were higher at 3.0 versus 1.7 for white females. And then I just wanted to show this slide also from the CDC about where we're seeing differences in new HIV diagnosis by region. And I hadn't seen this slide in quite some time, probably maybe 10 years. And as of 2021, the South accounted for more than half of new HIV diagnoses in 2021. So 52% of new HIV cases are from the Southern region, in comparison to, let's say, the Midwest at 13, Northwest at 14, the West at 20, US dependent areas at 1%. So this piece around the South is concerning, but you know what? I feel like that's been the case with respect to HIV diagnosis, like where they concentrated. We'll talk a little bit about community viral load, but those studies have taken place, and by and large do point to the southern region of the continental United States consistently. And so why might that be the case? Well, if you can't talk about sexual health and you can't talk about sexual disease prevention, in an open and honest way, that's one issue. Funding for on-the-ground community-based prevention programming probably does not exist in this region. I shouldn't say that. It's probably few and far between than say in comparison to the West, because I do know folks that are out there who are doing underground syringe exchange. So that's just something to consider, and think about our relatives who live in the South. There's a concentration of federally unrecognized tribes in the South. So that's also a dynamic to consider when we talk about access to care and access to resources and access to prevention. All right, so basics, HIV 101, routes of transmission. How do you get HIV? The most common way is to engage in sexual behavior without a condom. Another additionally high-risk behavior for HIV is sharing previously used syringes intravenously or even subcutaneously. Almost eliminated in the United States is, occupational exposure risks, particularly needle sticks, folks who work in emergency rooms or who in law enforcement, doing pat downs with there might be syringes or, we have a greater spread of sharps containers and access to sharps containers today than we did 10, 15 years ago. Almost eliminated in the United States. Almost another way HIV transmission has almost been eliminated in the United States. I would say probably through and through is through blood transfusions, as well as parent to child modes, perinatal, mother to child, as well as breastfeeding. All right, so there is a sequence of events once someone becomes HIV infected. There's what is an acute infection, which can last days to weeks. I think historically, this was talked about, folks who would be marked by flu-like symptoms. And I can think back to those days and people describing feeling sick, and it would be sort of a panic. Do they have HIV? Would be a question in people's minds. This is when the virus is replicating exponentially within the body. And you might have symptoms such as sore throat. You get a rash sometimes in your mouth called thrush, night sweats, fever, fatigue. So that can be pretty painful. That followed by this more asymptomatic infection, which can be 2 to 12 plus years, longer than that certainly, with treatment and care, where there is ongoing production of HIV virus in the body in tandem with a gradual depletion of T cells, which are the cells that fight off disease and infection. So you're losing your immune system essentially. Beyond that, what you don't really hear the term AIDS necessarily, but what is or has been referred to as more like advanced HIV disease. And that is when your T cell count drops below 200, and you also have what is known as an opportunistic infection. Those are wide-ranging. This is an important slide just to, if you're able to glance at it. It's called the treatment cascade, and it's just something to be aware of sort of in the work that we're doing. Ultimately is to prevent the spread of HIV. in communities, in tribal communities, in urban Indian communities, wherever people are living around the world. We want to stop the spread of HIV. And so what this slide is talking about is to me, it communicates the power of the medicines that we have now, as well as supportive services we know can help someone lead a healthy, long life, begins with someone who's initially infected with HIV. And in this particular cascade, if you will, we know that in the United States, at one point, there was 1.1 million folks who were HIV infected. Of those who were infected, only 874,000 actually got tested and knew that they had HIV. So right there, there's a gap, a little bit of a gap in terms of testing. We can always strengthen our testing. Of those people who knew they were HIV positive, only 655,000 were linked into care. So there's a gap there between knowing you're infected to actually getting into care. Never mind, only 437,000 were retained in HIV care. So we went from 1.1 million to only 437 who are actually in some form of HIV treatment and care. Of that, 349 are in need of antiretroviral therapy. That's the medication. Only 262 had access to it and were on the medication. And the ultimate goal is to have an undetectable HIV viral load. And of the 1.1 million, we know that 209,000 reached that stage. So every step along the cascade, we can strengthen our efforts collectively in Indian country. Whether you are working in sexual health or not, whether you are an alcohol and drug counselor, this is for you. Whether or you are working in nutrition or with women and babies, this is also for you. This is for everybody. And so treatment as prevention, research has shown the values of what that slide is really pointing to is antiretroviral therapy, the medications and how effective they are. Certainly in studies after study indicates reduced viral load significantly. And when an individual has a reduced viral load or a suppressed viral load, that significantly decreases the likelihood of transmitting the virus. Wow, we have come a long way in this work. A person not living with the virus now can take those same HIV medications to prevent themselves from infection. So we almost have what is close to, could be considered almost like a vaccine, but not quite, not quite. You have to continually taking it daily. But that is also a huge achievement in research and science. With respect to linkages to care, I don't know what the lay of the land is in Indian country today, but at one point early in the late 90s, there were absolutely structured programs in Indian country on reservations in urban programs that helped move people from diagnosis into stable care, helping Native folks who were scared, couldn't tell their families, didn't understand the disease itself necessarily, didn't know where to access Ryan White, how to actually get on the medications. How do I get to those appointments? All of the, there was structured infrastructure to provide some assistance to some folks in Indian country. I will say that those days, at least on the ground, the way the funding has dried up, are few and far between. And so I'm asking each of you to consider, to engage in these discussions with your clients, with your family, with your friends, to continue to keep this on the radar. Someone may need your support, and you may be the only person at your agency who is sitting in on this particular webinar, who may not have the answers, but knows you can reach out to not only me, or Steve, and to help to get the answers that you might need. Linkages to Care also you know, as a way to have a conversation about what will work for you, what won't work for you. Do you have insurance? Do you not? And linkages to care programs are not required for all folks, but, you know, I think is an essential service. Given that, you know, when someone learns that they're HIV positive, it can be very, very an emotional experience. All right, so let's talk a little bit about sexually transmitted infections. Steve.
Dr. Ignacio, there were a couple of questions in the chat I wanted to just throw out there.
Okay.
Mabel was asking, she said, is that PrEP?
Yes.
Okay.
PrEP is the, you know, I see commercials for it on TV. You can take PrEP once a day, and that will prevent you. That's the pre-exposure prophylaxis, otherwise known as PrEP. That is the medication you take to prevent becoming infected.
Got it. Got it. And then the other question Sonia asked was, what are the typical funding? What did she say? Oh yeah, what are the typical funding sources for this this kind of care and service? She mentioned Ryan White, but she was wondering what are the typical funding streams for this type of care?
Historically, HRSA has been one. IHS can be another. CDC has been another. In terms of care, treatment, and prevention, all those three different federal partners at the federal level. Then you go into different states, and different states might have some particular state funding. Some of that Ryan White care dollars. So that's the state level. There might be some money on the county, like in the South. But then tribes may have money, and for example, under my tribe, this falls under behavioral health. Great questions. Great questions. Yeah, if you have questions, just pop them in the chat. We'll get to them for sure. All right, STIs. Let's see. Sexually transmitted infections include those that are bacterial, parasitic, or viral. And they also have varying treatment and success with treatment. Excuse me. For example, bacterial and parasitic can be curable using medication. Viral, some are treatable, not necessarily reversible. Let me look at this real quick. HIV, right? Okay. Hepatitis, all right, good. It's also important to be aware of hepatitis C co-infection with HIV, particularly with folks who have a history of injecting drugs. Certainly, it's great if folks have access to routine testing for hepatitis C for anybody who's HIV positive. Early diagnosis, evaluation, and treatment of hepatitis C should be considered for HIV patients because there's benefits, right? Hepatitis C is damaging to the liver, and that can actually increase HIV progression. So that's not good. As well as hepatitis C viremia increases the disease progression, morbidity, and mortality. All right, so hepatitis prevention opportunities and existing programs. You know, it could be just an annual health screening, you know, all programs in essence. For, you know, the run of the mill, your average client is going to need some sort of level of education. They may need some level of risk screening and counseling. We know that many health clinics offer hepatitis A and B vaccination. Hepatitis C, not too sure about. That's a question mark. I wonder what they do where you work. But if we're talking about hepatitis C, you got to think about that HIV piece. They may have other needs, other counseling needs, other referrals. In this work, well, in my work, I'll speak for myself. Prevention comes first. And, you know, when we talk about prevention interventions, there's different levels. There's different ways we can do this work. When I say intervention, I'm referring to the mechanisms or strategies or tactics or program or curriculum, whatever it is I'm using to achieve a level of some level of change, like create some change. So for example, what would you do? Think about this hypothetically. What would you do to promote the idea of using condoms, particularly amongst somebody who just tested positive for, say, gonorrhea? That's a whole, if you've never had that conversation with a client, you might need to rehearse that ahead of time, probably in clinical supervision or in supervision, or with somebody who's been working in sexual health. Because we don't want to judge. I mean, we got to start there. We got to check our biases. We don't want to be judgmental of somebody who tests positive for gonorrhea, because that's going to ruin the whole moment. And so that's a whole education in itself, right? So intervention could be just learning how to unpack your own biases. Let's start there. Interventions are the opportunity to directly connect with individuals, communities, or systems, or institutions, or universities that are creating or perpetuating risk in order to eliminate, reduce, or mediate it. And the underlying thing is that interventions always try to change something. Interventions always try to change something for the better. And of course, as I say, there's different levels, so there's going to be different tactics. On a community level, homophobia, you might have a community where homophobia is rampant. So your intervention might be around stigma or anti-homophobia. And so you're really kind of getting at that community level norms. Whereas individuals who might not even have worn a condom or know how to use a condom might be a short 5-minute explanation of how to use it on an individual level. That's individual level intervention. So which do you choose? Think about your community, think about the culture. I like to think of culture first. What is the age, what is the age of this individual? If I'm working with an individual, ages are different cultures in and of themselves. So I like to just kind of think about those parameters. I like this as well as just a good reminder to consider the science. In fact, many programs today are, have to be rooted in evidence-based practice. And that's well and good and all, but, consider how the evidence supports the use of interventions among American and Alaska Native Hawaiian and or other indigenous people. And then it's also important to remember too, that, one does not necessarily lend to the other. For ourselves to know and our clients to know. Okay, so someone had a high-risk incident, that doesn't necessarily mean automatic, HIV infection. Okay, somebody just found out they had sexual intercourse with somebody who's HIV positive, that doesn't necessarily mean now that they're HIV positive. And so on and so forth. So we can be prevention workers along this continuum. Someone gets HIV themselves, okay, well, how do we address it so it doesn't get worse? How do we keep them healthy and strong and living a well life? And then certainly if somebody's HIV positive, how do we support them to help and not spread that to other folks? That requires education. At the very least. All right, so I want to talk about this intersection between folks who provide substance use, some form of substance use counseling or treatment or prevention in their work, and how that dovetails very nicely with HIV, hepatitis C, and STI prevention. They go hand in hand. As you all know, I feel like I'm preaching to the choir, but this is good, helpful reminders for us all. So why substance use providers specifically? Well, we counselors who have done the work and who are learning to do the work if you're a student have experience with behavior change professionally. And this also includes other allied professionals. I'm not looking at this in a narrow clinical way, but behavior change is a conversation that doesn't need to only occur among mental health staff. Behavior change is something that happens with the primary care doctor. It happens with administrators. It happens with peers. It happens in the family. But substance use providers, already are engaged with clients who are in high risk, who are engaging in high risk behaviors. So it's a not too far leap to have those conversations around sexual health. The work also instills a sense of accomplishment, self-improvement, and value of health seeking. So we can hold a mirror up to clients and say things like, I really just want to say thank you and acknowledge you that you came and showed up for your appointment. You came back for your results. That's really shows that you're taking charge and leadership of your health. And I just want to acknowledge that. And that's how you instill a sense of accomplishment in folks, I believe. And certainly the work reduces the number of injection drug use risks, particularly HIV, et cetera, and other choices and behaviors you might engage in while we're under the influence. People living with HIV require HIV treatment and disease monitoring. Yes, it is a chronic illness that will need to be managed daily, or I will not say daily, but there's medications that folks may need to take daily, but they will need disease monitoring consistently over time. Individuals, may not live a lifestyle that allows them to have consistent access, let alone they may have their own fears about having to go to the doctor all the time or consistently. Or those services may not even exist in their community. You may live in a community where there are no HIV specialists. So then what do you do? I'm thinking of tribal communities. But we, as service providers collectively, can be that bridge. Prevention seeks to interrupt the spread and perseverance of a condition. Substance use, substance abuse, and sexually transmitted infections and HIV can all be prevented. I think that's why I know I do the work, is because it can be prevented. You can avoid, you can make decisions now that can help avoid problems down the road. And it's a core function of public health and behavioral health practitioners around the world. I like this little visual. When we are helping to increase someone's wellness, someone's mental wellness, their mental clarity, they feel better about their lives, they're on their medications, they're working towards a healthier diet, they're trying to get their sleep in, they're exercising, they're doing all those wonderful things. All that work on the clients, that's all the client's choice to do that work, really, at the end of the day. Those choices also are simultaneously reducing the need for health complications, disease complications as a result of not going to the doctor. So you're promoting health and wellness through our prevention work. Okay. Behavioral specific interventions involve examining the individual and communal psychosocial components of behavior, in other words, environmental components of behavior, and implementing strategies to alter them. And again, this can happen on an individual, group, or community, tribal level. By medical interventions, use the medical science, Western medical science, to intervene. Western medical science technologies like PrEP. We talked about PrEP. There's also PEP, you may not have heard of, or you may have heard of PEP, which is pre-exposure prophylaxis. That was the very first one that came out, probably, oh gosh, I can't even tell you, 20 years ago, maybe. PrEP is a little bit more recent and has been studied extensively among various groups. And now the FDA has approved it. So that's great. And so when you take all these new technologies together with behavioral interventions, such as partner therapies, ongoing testing for folks who are sexually active, and supporting those who are positive with medication adherence, it's a win-win situation. And also the family. I think, I have a, what time are we at? Let me look at the time. Do we have time? Okay, I'm just gonna tell it anyway. The short story. One time I was working in Denver, Colorado, and I had a colleague who was working with a Native family who lived on the far eastern side of the state. And she was telling me about how in a rural area, rural Colorado, eastern Colorado, and she was saying how this mom, she had 3 little kids, but the one was older. This mom recently was diagnosed with HIV, and for many months couldn't bear to tell her mom, who also lived with her, and couldn't tell her family or the kids or anybody. But was also coming in for regular checkups. So because the woman was coming in for regular checkups, my friend said that you could see how the HIV virus was increasing over time, and her health condition seemed to be worsening because she couldn't, I don't know, the fact that she lived in so much shame, in addition to everything else, also was a compounding factor. Well, my friend worked with them and we'll work with the woman, and the woman agreed finally at one point to then have a session where she tells her family and her kid, the older kid. And so they come in for the session, and the mom discloses it, and tears and everything, as you can imagine. But at the end of the session, they're going to get through it together as a family. Okay, so here's the best part. A few months later, the woman came back, and now her numbers were all improved. Her T cells were up, viral load was down, she was feeling better, looking better. And my friend said, well, what was it? She was taking the medications, obviously, as well, but what else was helping you? What was helping you adhere to the medications? And the woman said, well, it was my daughter, actually. The daughter was 7, and she happened to have been the one in the room at the time. I'm going to get a little emotional. I haven't told this story in a long time. She said it was my daughter because as soon as we got home, the daughter dragged a dining room chair to the calendar that we had hanging on the wall. And she got out a marker and said, Mom, did you take your medicines? And she said, yes. And so she marked an X. And so the daughter took it upon herself to mark every day on the calendar whether or not Mom had taken her meds. I just think that's family. That's how it's supposed to be. And so family is a primary vehicle for health and wellness. Certainly in the short term, can create a social support network, obviously, help support access to healthcare, right, for rights and transportation, model positive communication and behaviors. I mean, look at what the 7-year-old daughter was able to do. Over the long term, certainly promotes values about open communication about personal issues, right? The mom was able to disclose. Value norms around diversity. That must have been a hard hurdle to now live with somebody who's HIV positive as a family. Think about that dynamic and that perspective. What does that mean? Which also lends itself to having open dialogues about sexual risk and expands our understandings of gender norms. I just think, that's the key piece here for today's message. And communities, of course. Communities have responsibility to establish resources and access to resources for HIV and substance use services. It could be as simple as a monthly talking circle. That does not require funding, people. And we also want to back this. It's not just so we can do these, yes, but we also need to put it in writing and create policies, whether it's in our policies and procedures or whether we add it to our mission statement. somewhere write out our policy that emphasizes health, wellness, equal access, and disavows discrimination. Again, that's also easy to do. It's not always easy to implement or to walk that walk, but that's the work. Communities also have opportunities to shape norms around sex, drug use, reducing sexual risk, reducing drug harm, prevent or encourage sexual substance use in schools and among young folks. And certainly we can think about creating or supporting policies around programs for those who inject drugs. And I think, just as a reminder, systems are the mechanisms through which formal services are delivered. You might have heard or hear a lot about systemic racism. And so this is exactly where we're at, rather, what this is pointing at. So systems are the mechanisms through which formal, let's put in funding, the funding for services are delivered, like how it all comes down through the funneling system down to the client. So systems have a responsibility to really understand the community needs and not just, develop them on their own. We want to align services to meet those needs and culture. We want to alter potentially harmful community norms, increase access to services, work through a health equity lens, and we'll want to modify systems to accept right insurance, but also be open to modifying systems moving forward so that we continue to reduce potentially harmful community norms, period. I mentioned earlier a little bit about community viral load. Thinking about the community as if it were an individual person. So just like a person has a viral load, a community can also have a viral load. So put it in plain language, looking at the sheer prevalence of HIV in one given community is looking at the community's viral load and working on that from that perspective. What can you do to lower the overall viral load that your community is experiencing? And this is important to keep in mind, particularly during outbreaks. You might see outbreaks with gonorrhea or syphilis. You pair that with increases in teenage pregnancy in a tribal community, then you got to start critically thinking about how to prevent HIV and other STIs. We talked about working on the individual level. Very often we work from an evidence-based perspective, culturally informed perspective. We use that cultural wisdom as well, community wisdom. I'm just going to highlight this one. Provide referrals and assist with medical linkage to care for those who do test positive for HIV or hepatitis C. That is the number one thing you could do. And I like to encourage a warm handoff. You find out, okay, so I'm saying this to you, but I'm actually talking to myself because this is how I would do it. I would do all the legwork to find out who the right person is in the community or who the right provider is, have a chat with them, and then get on a call where I can hand off the client to that individual. I think that to me is gold standard of care. There might be other ways, but that to me, if you're not working with a big team and you don't have a lot of time, which very many of us are, it's better than just saying, here's the number. And I think, now that I think about it, that was my training. My training as a clinical social worker was, here, you give the client the number and you don't call for them because the client should be motivated enough to pick up the phone and dial the number for themselves. Okay, well, that is all well and good, but we could save a lot of time by just facilitating that by me making the phone call first. Boom. That's my non-clinical, on the record, off the record, so unsolicited advice. Okay, we're wrapping up here. Thank you for your patience and your time. What else can a substance use provider substance use disorder provider do? Well, create an environment where it's okay to discuss sexual behaviors and identities. You have that training. You know how to navigate these discussions. You can do that in a professional setting, and you can do that in the personal settings. You can serve as a conduit for information. Again, being that point person, you can refer folks out. You can reach out to me. You can be that conduit for information for individuals and families. You can make condoms available. I was so excited. I went to a health appointment, and in the waiting room, free condoms for everybody. I like to see that. And you can also increase programming that makes syringes or sterile syringe access more accessible. All right, lastly, putting it all together, we work from a solution-focused perspective. Prevention services when working with drug users, active drug users, folks in recovery, folks at risk for HIV, folks for all the above, utilizes a positive service delivery model. By that, I mean we work from a strengths-based approach, which very often means really collaborating on an eye-to-eye level with the client. And I say that metaphorically, I'll explain that in a second. Collaborating with the client and write down strengths as a way to empower. Now, clients might have strengths, they just may never talk about them. No one's ever asked them. This might be a great session to have with a client to talk about what their strengths are. Have them write it down. You know, I think it's a way to kind of like build that internal confidence. And by collaborating with the client, you're doing it in a way in which they're the expert of their story. They're the expert of their experience. We want to address any overlapping, intersecting, or co-occurring disorders. We certainly want to work from we want to convey authentic interest. Mindfulness, if you've ever taken a mindfulness training, my number one recommendation for today, for everybody, is meditation. I have been a meditator now, I guess, for 4 years. I'm newer. 10 minutes a day. I started on an app called Headspace. I don't work for them. I'm not promoting them. But I had never meditated, but it taught me just 10 minutes a day over several years how to meditate. I currently use Deepak Chopra's app, just throwing it out there. I love it. But consider that if you have biases, if you have any hangups about working with certain individuals or clients, if you want to dive deeper into your own practice, you got to turn inwards through meditation, I believe. And it's also great for stress reduction. When we work with clients, we certainly want to acknowledge and provide support, like positive words for those positive steps that clients are making. Like scheduling not only an intake, but then coming back in. Those are all, when a client says, I need this, that it might not be in the prettiest, nicest language, but at least they are advocating for their needs. That's what we want. Great. And then you on the front line, your advocacy is the crowning glory of all this work, right? Because you've got that frontline perspective. You can see what the emerging trends are. You know what is happening in your community. You know which, for example, if there's an increase in fentanyl in your community, you see that because you're on the front lines. And I think all of this taken together is how we can support, positive environmental change. Okay, well, thank you very much for your time, y'all. It's been great. That's my email address. Feel free to reach out. I'm going to stop sharing. Thank you.
Thank you so much, Dr. Ignacio. Was that last photo, was that an actual shot of Tucson, the Tucson desert? I was hoping that.
Yes.
Good. I would keep this authentic here. Again, I want to just thank you for presenting. We do have a little time if anyone has questions or any follow-up thoughts or comments they'd like to make, we can open the floor. But I want to thank everyone for attending today and being with us during this time. But I'll open the floor now for questions. Anybody want to have a question for Dr. Ignacio?
Hi, this is Mabel. I don't have a question, but I do appreciate your presentation. I worked for the STAR Clinic, which is an outpatient HIV with Ryan White funding HRSA and CDC. And one of the things, and I worked as an occupational therapist and a mental health counselor when I was accruing my hours. One of the things that I know that we provided, as you said and mentioned, Matt, that there were condoms available not only in the waiting area, but also in the back where clients would come in to meet with either the case manager, the doctor, or the nurse. There were also the different gels, lubricants, just like a big bowl. You know what I'm saying? It's nothing like they would feel like they need to come to you individually, but it was always made available in different areas of the clinic. And then we also had a health management group where people can bring up issues. And if it was sometimes just a men's group or a women's group, and that was one of the things that I think that helped them to see that this was a clinic that really was very welcoming and that really cared about certain issues. And I guess it was welcoming enough for them to be able to open up to their counselors and their doctors and nurses and even case managers. Like people just felt welcoming and they opened up to whoever they felt they needed to open up, even if they didn't have a scheduled session with their therapist. Maybe they had a scheduled session with their case manager.
Yeah, exactly. Just increasing access. And I lived in New York, used to work for the Harm Reduction Coalition at one point, and at that time, the health commissioner wanted to quote unquote cover the city in latex and wanted to put condoms in barbershops and beauty salons and at schools. And so I'm glad to hear that that sort of vibe is still continuing on. That's great. Awesome. I also did see a comment about hepatitis C. Yes, it is curable to hepatitis C. It's access to that care though. Can you get that particular kind of treatment if you're living in a rural community? That's a specialized treatment. Does IHS cover that? I mean, those are all questions that are going to emerge.
Dr. Garcia or Ignacio, you also said something about, well, as you've talked, I've also heard kind of an undertone regarding harm reduction. And I know, we didn't pinpoint it specifically in this presentation, but maybe just offer some thoughts on harm reduction as it relates to this topic and
sure,
this discussion.
Well, so I started HIV work in '99. It wasn't until let's say 2000 and, well, I guess it wasn't that long, 99 through 2003. So that first chunk of time was really all about sexual risk behaviors, promoting condom use, make sure you get tested, reduce the number of partners you have. These were all like what we would communicate. Use lubricants to decrease friction and skin tearing. It was really centered around sexual risk. In 2003, I moved from the West Coast to New York City for a job. The job was at the Harm Reduction Coalition. And I didn't know exactly what harm reduction was, but I had mentors who were saying, oh, that's cool. You should go there and do that. I'm not like that, but I mean, they were like, oh yeah, harm reduction. Like they got it, I didn't. When I got there to the job, I'm like, oh, okay. This is about drug use as a risk behavior. It was almost at that time, they were siloed discussions around how someone can get infected with HIV. When I got to the Harm Reduction Coalition, as somebody who was raised during Nancy Reagan's Just Say No campaign, very abstinence-based perspective growing up. And my parents were very conservative and were anti-drug and alcohol. even though my dad used alcohol, they were very anti-drug and alcohol for their home, for us kids. And so harm reduction was basically like, okay, you can still be an active user and you can also still care about your health. Both can be true. And if you are an active user and you also care about your health and want to increase your health in some way, some form, I can help make that happen. I can help create that positive change in your life. We can find a way to make that happen. So harm reduction to me is like, oh, well, that's just like common sense. That's like tribal wisdom. You know, you may not have access to the top grade, but you'll find a way to make do with what you got. You may drink a 6-pack of beer every single night, and you may not like the way you feel the next morning. So maybe let's try to reduce that to 4, or maybe even 3. Can you swap in some glasses of water? I mean, I don't know. This was all the work that was taking place, but it was squarely centered on preventing harm from drug use, including not only addiction or persisting, substance use disorders, but also HIV, hepatitis C, et cetera. That was a long story to answer your question, but both are essential. We got to talk about sexual risk and we got to talk about drug use as a risk factor. And I prefer to have those discussions in a non-judgmental way.
Yes. Thank you. Other comments or questions for Dr. Ignacio on these topics? Looks like, oh, there, is that Penelope?
Yeah, I was just going to say, I had a client recently. He didn't stay very long, so I never got to get more information about him, but he was diagnosed with HIV several years ago, and he is on the med, so he said he was doing fine. And he said that the only reason why he found out was some issue with his husband at the time, and so their doctors, or his doctors, informed him that his husband had HIV, and so then he was tested and found out he had it. So he didn't know anything like how long he had it and all these other details. And so I asked him, like, had you been getting tested regularly? And he said no. And he said, they don't tell us these things. They don't tell. And his words were something like, for gay people, they don't educate us or something. And so, I mean, I'm not gay. And so I was really confused because I felt like for anybody, like it's common good practice to just get tested regularly if you're sexually active, I guess, or I don't know. So I didn't know if you had any kind of insight on why he would feel like he didn't need to be getting tested.
Yeah, I have just 2 thoughts on this, 2 main thoughts. One of which is yeah, so as a provider myself, I run into this with my family. I'm thinking about this. This happened just recently, and it happens kind of more frequently than I like to see, where family are saying things that it goes against my prevention training, and I can't react because I don't want to like create any issue. So similarly, and so sometimes I have to reflect. I have to start with myself, right? Remember I said it kind of begins all with us. So in those moments, I put myself in check and I go, okay, Matt, you're looking at this through a trained eye. That's what, and you've had years and years of like training and discussions and coworkers and mentors that you just automatically see it and you can clock that. So I have to check myself in that regard. The second piece is, yeah, it's HIV, let's just talk about HIV specifically. That is such specialized prevention information that folks don't get nowadays, the way it was in like the late 90s, early 2000s. That whole landscape has changed where it's not discussed. It's not talked about. So why would somebody want, the primary doctor probably, I'm not to put primary doctors down. I just don't, it's not a conversation on folks' radar, I don't think. And if that individual, let's say not him, but somebody like him, may not feel comfortable disclosing their sexual orientation with their primary care doctor, that may never even be, and the HIV may never be on the doctor's radar.
Oh, okay, okay.
That's not uncommon, not uncommon at all.
Okay, yeah, I guess that makes more sense. Definitely, there was a time when it was more widely discussed, and I guess it's because I'm guessing because of the meds that are out there now, it's not, doesn't have that like same urgent, scary feeling.
It's true, and I hate to admit that. Yes, I think when that was, you can pinpoint the year, like 95, when the meds started. Were on clinical trials and just about to be approved by the FDA. Things changed when folks kind of got it in American culture, like, oh, well, we're not at risk. But okay, that's, some people aren't at risk. Think about tribal communities, or folks who are poor, or folks who live on the edge,
Right,
or who are homeless. That it's still a risk for them.
right.
Yeah, I love this discussion.
It was kind of sad because he left suddenly. He was detoxing. I forget what he was a meth user, and he wasn't feeling well. I don't think he was feeling anything. Like, for us in this program, like, we were like, oh, that's normal. You're detoxing. You should feel like that. And he was convinced that he was going to die soon because he was having like an HIV related flare, and we kept trying to tell him like, no, he's like, you're gonna be okay, but he left, and so I don't know where he is now.
Yeah. Wow. Well, thank you for the work that you're doing. Appreciate it.
Thanks. Yeah, and so when like those kind of conversations come up, I do think of it from as a provider, because I've done this for a while, but I also feel like I don't really know what else to say. Like, these aren't conversations that I'm used to having, but like, so that's why I was like, this is actually a really good training for me, because some of the stuff you brought up to me, like, I was like, oh, it was basic, but it was also like, oh shit, I can't believe I didn't think of that. Like, to me, I just think everybody knows like how to put on a condom. So I didn't think like, oh, maybe they don't know. They never learned that, whatever.
Yeah, exactly. Well, good. Glad to be here today. Thank you. Awesome.
Thank you, Penelope. Other questions, comments before we close things out?
I wanted to make another comment. This is Mabel again.
Sure.
One of the things that I know that the clinic was working on was working with barbershops, sort of trying to, number one, educate and promote and engage them in the prevention components of whether it's STIs or it's either HIV. And, I think that was actually good initiative at the time. I know it's still going strong. So I'm wondering if that's true in your Native communities.
Oh yeah, those community level spaces where everyday people occupy are excellent intersections to share helpful health information. Barbershops in the Black community, certainly when I lived there, that was a targeted effort, and it was made groundbreaking. Similarly, I can think of a time when you would go there was a time when powwows were very anti condom access. I'm just from my limited one-person experience, nationally speaking. About maybe late 2010 or like somewhere in there, things shifted, and you could have a booth set up at a powwow. You could have condoms on the table for folks to take at a powwow. Elders were certainly becoming more aware of the need for prevention. And actually, elders were, in some communities, the one who stepped up. Elders were the ones who stepped up and were the community leaders around HIV prevention, because they had no hangups about talking about sexual health among their grandkids or their young nieces and nephews, the ones that they could, the ones they oversaw. So other community, oh, so my favorite one, I'll just close with this one. My favorite one was this one in the Plains region, a tribe up there. And so one event that a lot of communities do is host a national HIV testing day. I don't remember the day off my top of my head. Incidentally, the National Native HIV/AIDS Awareness Day is March 20th. That coincides with the spring equinox to reignite a new fire, recommitment to preventing HIV in Native communities. So on March 20th, many communities host testing events. And so this particular community in the Great Plains region hosted a testing event with their tribal health center, where people by and large know everybody. Folks aren't going to come up for a free t-shirt and stand in line for an HIV test just because they want to. Factor in stigma and homophobia as well. But what they did to get around that was anybody who got an HIV test was entered into a raffle to win a chainsaw. And there was a line out the door. Women and men were trying to line up to get that HIV test to then win that chainsaw. So, I mean, that's another example of a community level intervention.
That's the chainsaw effect. Oh, this has been great. Again, I want to just thank everyone for attending today and being present with us, and of course for Dr. Ignacio for hanging out with us this last hour or so. And always good to work with you, Matt. I appreciate your knowledge, especially in this area. It's really it's important that we continue this dialogue because it's still it's not over, and
That's
your
right.
numbers and data reflect that. So thank you again, everyone. If we don't have any other questions or comments, we are going to go ahead and conclude today's broadcast. We will be broadcasting first Monday of next month. Be sure and look for the announcement on that. I'm trying to remember what our topic is for August. I think we're going to be talking about group counseling. I just had to check my whiteboard there in case the system all comes down. I'm going to have everything I need on my whiteboard behind me. So that's my backup system. So join us next month if you can for group counseling. It'll be a good refresher again for those of you that are doing this kind of work in the helping profession. So again, I want to thank everyone. Until next time, please stay safe, stay healthy, and most importantly, stay connected. We'll see you again soon. Take care.
Thank you so much. Bye-bye.
Bye. Thanks, Matt. Thanks, everybody.